and so that it will be available for future viewing if you have colleagues who weren't able to make it or anything like that. So with that, I am going to turn it over to Dr. Tilson.
Great, thank you very, very much. And yes, the rumors are true. I actually was with patients this morning, and I think it's a great soul-nourishing thing to get to be able to be one-on-one with the patients as well, and then bring that perspective to the broader work. So that is true. Friday mornings, I get to be a pediatrician, like hopefully most people also on the phone. So really, really happy to be with you all. Really, really happy for this opportunity. And we have an hour, and I think, well, I'll talk for maybe about 40, 45 minutes or so. I might gloss over some of the data stuff just so that I don't bore you to death with some of the data, and then allow for some Q&A as well. And this will be recorded, and this will be archived. So some of the slides, and I'll go over a little bit of the data. I won't go into all that data, but you will have those slides if you want to reference them, or you want to use any data points yourself, then you'll have them as a reference as well. All right, so let's get into it, and also thank you for spending a beautiful Friday afternoon in the summer on this really important topic. And the first thing before I get off this first slide is that I wanted to, I hope you'll get a sense of the view of health that the department has, and we're really trying to embrace a holistic sense of health and well-being. And part of that you might see reflected in my title, in that traditionally the state health director was siloed in the Division of Public Health, but I think we know that health, the Division of Public Health is an incredibly important piece of health. Public health can't do it alone, and public health really works best when it works in collaboration with other segments of our health system, but also our systems as well, and thinking about economic and all the different aspects of health. So this aspect of the Chief Medical Officer is a new position, and really I think reflects the Secretary's priority of holistic health. So this piece, the Chief Medical Officer piece, is that I'm rooted in public health, but then I also get to intersect with Medicaid, the Medicaid of today and the Medicaid of tomorrow, Division of Mental Health, Division of Social Services, all those different divisions, so we can start thinking about pulling the department together in a holistic way. So I say that only because I hope that sets the tone for how we're trying to think about holistic health. So the next slide is, I like this because I think when we talk about social determinants of health, and we also talk about that, we're going to try to change that language. Social determinants of health is probably not a great term, and we're thinking about other language to use around it. But this concept of social determinants of health is certainly not unique to the department, and it is certainly not a new concept. And I think if you look across many agencies, you see the concept of what we're trying to talk about, this very interrelated, multifaceted vision of health. And so on the left is the Institute of Medicine. In the middle is Robert Wood Johnson. And this graphic, I think, is when people hear that clinical medicine maybe only affects 20% of your health, I think that's where that data comes from, or that talking point comes from, this RWJ one in the middle. The one on the right from the World Health Organization, I really like that one because that really gets into this idea of equity and power and resources, which is just an incredibly important piece when we think about social determinants and equity and disparities. And so I really like that piece that WHO brings in. And then the middle on the bottom, I like this one as well to also show that it's not unique and it's not new. So this was back in 1910 in the Flexner Report, where Abraham Flexner said that the physician has a duty to promote social conditions that conduce to physical well-being. So we've known it forever, we just haven't really acted on it. And so this, I think, is a chance for us to really act on it. And it really feels like this concept of social determinants of health is really gaining momentum. So we really hope to be able to take advantage of this opportunity and hopefully to truly impact the health and well-being of our North Carolinians. When we also talk, you'll hear some of the concept that we want to buy health. And so when we think about where we spend our healthcare dollars, we spend most of our healthcare dollars in direct medical care. But when we know that so much of our health is impacted by things outside of the medical care, we just have a huge mismatch of where we are spending our money. So we really want to think about how do we spend our money differently, not to take anything away from medical care, and we absolutely think access to high quality medical care is critical. So we don't want to take any money away from medical care, but how do we start investing those other pieces that are really, really important to health? So that's a mismatch that we have, not just in North Carolina, but in the nation as well. And so how do we change that mismatch? Because we know if we start looking at some of our data and the more global data of our population, we aren't buying health the way we're spending money now. And so the next couple slides, I'm just going to go through some of the data around some of our, what we think of some of our core priorities around social determinants, and then thinking and a little bit around the evidence of if you intervene in some of these avenues, you can not only improve health, but you can also decrease costs and that strong economic return. And I will say up front that I think this concept of social determinants of health is so big and so wide, and there's so many things that go into it. There is structural racism, there's health equity, there's jobs, there's economy, there's the workforce, there are so many things. So I don't want to sell all those aspects short, but I do want to upfront say, to start with, we are prioritizing 4 core domains, and we're prioritizing them, one, because we think they most closely relate to health outcomes, and we can show some economic ROI. And if a lot of this we want to pay out of our health dollars, we feel like we probably need to do those ones that are most tightly aligned to health outcomes right now. So, so areas that we're focusing on to start with will be food insecurity, housing stability, transportation, and interpersonal violence as a core. And just to start focusing some of our work, not to say all the other stuff isn't important and we need to think about how to piece it in, but that's where we're starting, just so you're oriented that way. So then getting into some of those priority domains. So example, we think about food insecurity, and in North Carolina, we are not doing great in thinking about buying health and buying food security for our North Carolinians and especially our children. So we have the second highest rate of food insecurity for our youngins. And if we think about the importance of proper nutrition in healthy brain development, that does not really, that sets up potentially a trajectory of poor health outcomes. So we really got to think about good nutrition and a lack of food insecurity for our young ones. We also know that if people in general and kids that are in environments of food insecurity, they have overall decreased health, increased hospitalizations, increased healthcare costs. We know that it can impact their development and then their school performance and their long-term academic and employment history. And we also know that the food insecurity experience with kids as young can extend also then into physical health conditions in adulthood. And so there's a lot of reasons why we think food insecurity is a really important area to focus in on. And then we have some really nice hardcore data as well. So this is a little bit more adults, but it translates to children as well. So we know that there's increased health costs associated with food insecurity. And so here you'll see that there's almost a $2,000 difference per person if you're food insecure versus food insecure. And then the lovely thing is we also have great data to show if we address that food insecurity, we can not only improve health, but also decrease costs. And so really thinking about that return on investment, that economic argument that we can think about if we're going to start using healthcare dollars, we need to think about that return on investment in healthcare savings. So this was a really nice study that looked at if we had our seniors who were food insecure and we connected them with SNAP and improved their food security, then we had a nice economic return on investment and decreased costs of care for those people. And a lot of that cost was decreasing admissions into nursing homes. So we have really nice data to show if being food insecure is really bad for your health, short-term and long-term, increase healthcare costs, and if we intervene, we can improve health and decrease healthcare costs. So that's a really nice data set there. Then we think about housing, really, really important. We have issues with affordable housing, we have issues with housing quality, and we also have issues with just housing instability completely and people being homeless. And for this audience, I will highlight too that we know that the most rapidly growing homeless population are families, and that primarily moms and children and primarily infants. So moms and infants are rapidly increasing population who are experiencing homelessness. And the most likely reason for this population experiencing homelessness is they're fleeing from domestic violence. So now you have the combination of interpersonal violence, homelessness, and then food insecurity, and then transportation. And so housing instability is just a really big marker of all sorts of other instability that can have really lasting effects on health. So we think that housing instability is a really important piece for us to think about it and holistically. And just like with the food data, we also know that there is study after study after study after study that shows if you have a someone experiencing housing instability and that has high healthcare costs, if we can house that person stably, we can show really quick decreases in their cost and their utilization and a really strong ROI with housing. So we have lots of evidence to show that housing is healthcare and good rationale why we want to think about how do we get more people stably housed and then address all the other issues that may have had them be housing unstable in the first place. Next, we want to move on to transportation. We know that transportation is a big barrier to healthcare access, and especially in our rural areas. It is one of the biggest things we hear when we travel out to a lot of our rural areas is our transportation is a huge barrier. In fact, I was just in a Hosky yesterday visiting the dental clinic, and it just so happened real time yesterday, but we were speaking with a dentist, and he said, we're taking care of a gentleman right now. He walked 10 miles to get here. He has an infected abscess, and he's not sure that he wants me to remove the tooth because then he's going to have to walk 10 miles home, and he's just not sure he can make it in the heat after the surgery. And so transportation is just enormous in terms of healthcare, but it's also enormous in terms of connecting people to community and to social settings, and we know social isolation by itself is also really, really bad for your health. So thinking about transportation to health care, but also transportation to health, to your faith community, to parks, areas to exercise, or just places that you can intersect with other people on a way to decrease social isolation. So transportation is a really big issue, especially in such a big state where we are and such big rural areas where transportation is a big barrier. So another area. And then finally, interpersonal violence. We have one statistic that is always quite shuddering to me, that almost half of our women in North Carolina have experienced interpersonal violence. And we know that women experience interpersonal violence that can be directly linked to their health and also to their pregnancy outcomes. And not only in the physical, but mental health as well. And we also know that women who are experiencing interpersonal violence, if there's children in their home and the children are witnessing that interpersonal violence, and there's a two-generational effect in terms of interpersonal violence, which then gets us into this concept of adverse childhood experiences. And hopefully most of you on this call have heard of ACEs and adverse childhood experiences. And that this is this landmark study back in 1998 where really looked at the relationship of childhood abuse and household dysfunction and how that relates to leading causes of death in adults. And hopefully most of you know, but just to have it here, so thinking about the historical ACEs, adverse childhood experiences, were childhood abuse, so physical, sexual, emotional abuse, and then household dysfunction, so having a parent with severe and persistent mental illness, having a parent struggling with addiction, and we think about this, we're in the throes of an opioid epidemic, and our parents struggling with opioid addiction. What's going on with the kids in those households of those parents who now are experiencing ACEs because of their parents struggling with addiction? Incarcerated household members, thinking about parents being separated from, or children being separated from their family. Clearly a huge issue in immigration right now in North Carolina and other borders, but kids being separated from their parents and their households being separated. And then, and as I alluded to, violence between adults in the household. So those women, and not just women, some men also experience interpersonal violence. I shouldn't be too gender focused, but our parents experience interpersonal violence, and the children witnessing that is also an adverse childhood event. So we feel this concept of trauma is so important and so pervasive, and the evidence behind ACEs and our and long-term health effects, that we really felt like we needed to get into the trauma world, which is a little bit scary, and we're going to have to do it delicately, but we felt like we really needed to go into that trauma space. Most of you, I hope, know, and I'll just talk a little bit about the neurobiology of ACEs, just because I think the science behind this is so strong. But a little bit of stress is good. A little bit of stress helps you to perform better, helps you go on, helps you flee whatever might be threatening you. And even long-term stress is okay as well, as long as you have that buffering relationship that can help you calm, help you regulate. Where you really get into trouble in that concept of toxic stress is that you are in this constant stressful environment with a threat after threat or threat, and then you have no buffering relationship and no way to actually help buffer and regulate your system. That's what we're talking about in terms of toxic stress, and the effect of that experience on your evolving neurobiology is really quite remarkable. This looks at a picture. The top is a normal neuronal complex with all these healthy neurons and brain cells connecting and thriving and growing. And then bottom is a toxic stress. So this is the brain cells and neurons who are experiencing that toxic stress. And what the chemical that is emitted during toxic stress is cortisol, which is one of your stress hormones. And so if your brain and your brain cells are constantly being bathed with cortisol, it is a neurotoxin, and your brain cells are getting killed by that intense exposure to cortisol, just like lead, but cortisol is a neurotoxin. And so that is the true neurobiology of experiencing this toxic stress. And that's some of the at the neuroanatomy level. This looks more of the functional level. And so on the left is a healthy brain, and you can see all the different parts of the brain lit up. On the right is a brain of a child who's experiencing toxic stress and abuse, and you can see the true functional changes in the brain. And most remarkably is that in the front is that frontal lobe that helps with your executive functioning, your higher order thinking, your cognition, helps you adjust multiple demands at a time, help you think about delayed gratification, higher order thinking. When your frontal lobe now does not have all those neurons that it needs, it really affects your ability to be successful in school, to be successful in life. So true brain damage from this toxic stress. So incredibly important. We feel like we need to think about it and how can we protect our babies' brains. There's a little bit of Cascade that shows this concept of adverse childhood experiences disrupts our neurodevelopment, stress on the end organs, and then this cascade into just death and disability. So if we can get at the base of that pyramid, it could be a huge lever for us to really change the trajectory of the health of our North Carolinians. This just looks at, the CDC has a really, really great website and a really nice library of studies that look at over and over and over again, a very, very reproducible model that the number of ACEs that you have increases your risk for 40 plus or so health outcomes. So really strong data that ACEs are incredibly important for your long-term health. And so why do we think it's important? Well, lots of reasons. It's great neurobiology. It's also incredibly prevalent in North Carolina. This slide looks at our overall North Carolina population, and about a quarter of our population have experienced a high ACE score, meaning 3 or more of these adverse childhood experiences. People are pretty resilient and can typically handle 1 or 2, but once you get into that 3 and above, that's where you really start getting some of that neurotoxic effect. So about a quarter of our population have experienced high adverse childhood experiences. And then as we think about going into Medicaid reform and we think about what our Medicaid population looks like, if you break down that prevalence of ACEs by insurance status, it is really compelling, we think. So this graph looks at the cluster of graphs on the left are 0 ACEs. The middle is that low 1 to 2 ACEs. On the right is the 3+ ACEs, the high ACEs. And so if you look at that kind of dark, kind of Duke blue line on the far left of the cluster of bars, that's our Medicare population. And you can see more people in a Medicare population have had no ACEs than high ACEs. Only about 15% of our Medicare population have high ACEs. The next one, little Carolina blue, is our commercial population, and same thing, you'll see more people have no ACEs than high ACEs. You start leveling it out in our military population, which is that middle. Then the gray bars are more uninsured population, and you start seeing that pattern flip. And by the time you get to our Medicaid population, that pattern is completely flipped. So now more people in our Medicaid population have a high ACE score than a low ACE score. More than 40% of our these are our adults covered by Medicaid have a high ACE score. So we really felt like we could not go into Medicaid transformation without really thinking about the effect of trauma and ACEs if we really want to improve the health of our population covered by Medicaid, which we do. So just like with the other social determinants, there's great evidence of what you can do to either prevent or respond to ACEs, and there's a lots of work around resiliency that we want to tap into. So not just say, oh, you've had trauma and you've had some brain damage, but how do we bring in the resiliency and support our families and support our people? And so you really can offset a lot of that adversity with resiliency. And so that's what we really want to focus on. There's some resiliency that we're thinking about at the provider level, at the individual level, and really thinking about how do we become a more trauma-informed state, a trauma-informed system, trauma-informed schools, trauma-informed care, and really having people understand I won't say trauma is universal, but quite prevalent, and starting to think about kind of universal trauma-informed care, and not continue to re-traumatize our people, but giving people an area of safe and therapeutic environment, understanding their history of ACEs or trauma, helping to switch conversations from, what's the matter with you? Why are you so non-compliant? Why are you acting the way you are? To thinking about what happened to you, thinking about is the trauma talking, and really unlocking some of that compassion. So really thinking about focusing on trauma-informed care, which we know can be really, really effective in creating a therapeutic relationship and then good health outcomes for our people who've experienced trauma, but then also thinking about what at a community level we can do to prevent or mitigate trauma on a more population level. And there are so many evidence-based interventions, thinking about family resiliency, I'm thinking about early childhood, thinking about economic support, and hopefully you're very familiar with a lot of these that we have in North Carolina, Triple P, Parents as Teachers, Nurse-Family Partnership, a lot of our home visiting models. So we have a lot of those programs as well. How do we further invest in those evidence-based interventions to really foster our family resiliency and bolster that nurturing and buffering response. So we have all of that data to know that our population, we really need to do some more work in improving the health and well-being of our population, and we also have all sorts of great evidence-based interventions to affect them. So yay! So how do we go and roll that out on a population level, on a sustainable level, that we can think about funding mechanisms to really make this go for our population as a whole. And so this is our vision that we are trying to be true to and live into, that we really envision a North Carolina that optimizes health and well-being. So care gets you to health, and health gets you to well-being. And that's what we really want as our people, having social and emotional and health and economic and education and well-being, that we want to be for all people. And we will talk about some things that we're doing within Medicaid, because that's a lever that we can pull. But we don't think this is just a Medicaid only thing. This is for all of our people. And we really want to think about effectively stewarding our resources. If we know that 80% of your health is determined by things outside of healthcare, and we spend 90% of our dollars in healthcare, well, that's not really we're not effectively stewarding our resources. And let's think about how do we steward our resources into those places where there's a lot of evidence that we can really change trajectory. So we want to be very mindful and good stewards of our resources. And then we really want to think about how do we bridge our communities and our healthcare system to really be able to live and breathe this and make this a reality. And we want to go as upstream as possible, so we can get a lot of savings in our healthcare system by focusing on our medically complex, high-cost adults, and that's great, and we need to do that, and we will be doing that. But we can't just stop there. We also have to think about that early brain development and preventing trauma, and go far upstream as possible, and have a balanced portfolio so that we can make this be economically sustainable. So that's what we're hoping to do. And as I mentioned, these are our 4 core domains that we're focusing on in the beginning to kind of get some good ROI and some concrete tools and evidence. This is our multi-layer map of how we're really trying to do it and how we're really trying to roll it out statewide. We know there's so much rich work being done at the community level, and we absolutely want to support that and encourage that. But there's a little bit of kind of shotgun approach, and many people are doing great things, but there's not a great connection, and there's not really a good statewide framework that can support a lot of that work and connect that lot of work. So that's what we're trying to do, is build a statewide framework to support this. There's several different layers into that, and I'll go into each of those just a little bit, and then we can talk about Q&As, that which you want more information on. But I wanted you to see the full suite of the activities that we're trying to put into reality. So the first tool that we published, and hopefully many of you have seen this. It's been out for about a month or so ago, but this was out of our State Center for Health Statistics. We published a map that looked at social determinants of health indicators across the state. So looking at social and neighborhood indicators, looking at economic indicators, looking at housing and transportation indicators. There's a lot of maps coming out now, which I think is great, and this is kind of one more map in our toolbox. And we think that it'd be a nice starting point to think about if we're going to do community investments. It's a nice way to kind of codify and guide some of our community investments. I hope a lot of you have already seen this map, but if not, I'll just kind of show you what it looks like. Right now, it's broken up into our North Carolina local health department regions, but we're going to do a revision of this and also have it just be a statewide map, and you can kind of do whatever region that you want. And then what you can do is you can drill down into any of those specific indicators if you want, and just for example, I chose food deserts. And this is in Region 5 in the middle of the state, and it will highlight those areas and those counties that have been designated as a food desert. It's really nice to think about, okay, if we want to put a food pantry, we want to put a grocery store, this is a nice way to think about community resources or planning. And then you can also scale, roll these all up and have a cumulative index across all those social indicators to show this kind of your hot spotting of social determinants. If we're going to really invest in communities, these are those hot spots that we really want to think about investing in. So that's just the first nice tool, I think, for planning, and we're collecting some case studies and kind of best practices of how people and communities have used this to help people have some tangible ideas. Next, hopefully a lot of you heard that there's a lot of people starting to screen for different social determinants, and there's a lot of tools out there, and people are really kind of excited about this. And so there's a little bit, the excitement is great, but we're at a little bit of a risk of having a Tower of Babel and having people all coming up with their own screens and all using it different ways. And it's great to be collecting that information, but we feel like we'd be missing an opportunity if we didn't think about how can we do this together in a somewhat standardized way so that we can then start thinking consistently, gathering some of that data that can really help them to continue to inform where we need to invest resources. So we convened a pretty robust technical advisory group of stakeholders to help think about, what's out there, what are the best tools, what are the best validated questions, what are people using, what's priority, and can we come up with a proposed set of questions. This was the first draft, and that was out for public review. It closed a couple weeks ago, forgive me, and you'll see some of the proposed questions. We got really nice public feedback. I mean, not nice in terms of complimentary, although some of it was complimentary, very useful public feedback, and the TAG just reconvened about last week, and we're thinking about tweaking some of this as well. And we want this to be available for folks. If you want to start screening, great, and you were looking for a tool, we want to make this available for people. We're not going to be mandating it at any level anytime soon. We hope our providers and a lot of different areas will adopt it. The first place that we will mandate it is as we go into managed care. As people enroll in managed care, that as part of initial care needs assessment, if they're asking about what medical problems you have or what medications you have, they're also asking these questions as well. And so routinely screening for social determinants as people go into managed care. That'll be the first place that we mandate it, but we also know, and actually we hope, and actually we know that a lot of our providers are starting to screen as well, and so we wanted to make sure that was out there and available to people, and as we further tweak it, we will make sure that you have the updated tweaks. We also know that if you just screen, we don't want you just to screen, we want then you to be able to say, and how do then we connect our families and our people to resources. And so that's the concept between this resource platform. And so what we really want is a statewide kind of public utility that'll be open to everybody, open to just people, open to communities, open to providers, open to care managers, open to payers, systems, open to everybody. And so people can use it across all of their populations, their commercial populations, their Medicare populations, their uninsured, everybody. There can be one common platform that everybody can use. With a couple functionalities. One would be a well-curated database of community resources. So if someone screens for food, you can pretty easily find out what are the food resources that are close to where that person lives that matches the eligibility they may have. But then even more exciting is this referral piece of it, that we can then have these community-based organizations upload on the platform, and you can actually do a referral directly to that food pantry, and they'll know that Mrs. Jones is coming. And then to be able to close that loop and say, hey, Mrs. Jones came and she got a food box of medically tailored food. And the same way that we do referrals back and forth to our medical providers, we can refer back and forth to our social services providers. If we think that food is medicine, then we should be really connecting in and closing the loop of referrals to our food providers, just like our cardiologist. So we're really excited about that. We want it to be statewide, so we recognize it's going to need to be really flexible and to be able to connect into other systems that people are using. And we also know there's going to need to be a lot of work and technical assistance to our providers and our community-based organizations to really get people up on the system and using it. So we are excited about this. We are doing this in partnership with the Foundation for Health Leadership and Innovation. And so they will be the ones that will be holding the contract with the vendor. And they released the RFP last month. It just closed last week. And the goal will be that actually we got a really, really robust response to the proposals. And so the goal will be that the vendor for this platform will be chosen by the end of this month, and then we can start really doing that work and working with our communities and really making it happen and start rolling it out across the state. So we're really excited about it. We have been able to secure a lot of private money to invest in the upstart and development of this, so we can make it available to people and really show that value add over the next 3 to 5 years. So we're crazy excited about that, and you'll be hearing more about that as it gets developed. The next piece, I said that social determinants is not a Medicaid-only thing, but really important in Medicaid. And Medicaid is a lever that we can absolutely control and we will control. And so what I hope you are seeing in a lot of the white papers and the pieces that we're communicating about Medicaid is our priorities. And our priorities, I hope you will see loud and clear, is this concept of social determinants of health or holistic health. And so there's things that we'll be rolling into it. As we mentioned, in terms of care management, we expect there'll be care management around medical. We also expect there'll be care management around food insecurity and housing instability. We expect there'll be a standardized screening for our domains and expectation to navigate to those resources. We will expect that our care management team are well-versed in trauma-informed care and the importance of trauma and resource navigation. We have one statewide quality strategy where we will highlight those things that we think are important. And in our quality strategy is this: we will be prioritizing, identifying and navigating to social resources. We will be, there's different levers we can do. There'll be a lot of different quality accountabilities that'll be out there for the plans, but the ones that you really think are really, really important, then you have a strategy of a withhold, that if they don't meet performance on this measure, we will withhold money and we will only give it to them if they meet expectations for different measures. And one of our withhold measures will be screening and follow-up, and we think it's so important. And we also, a huge opportunity of going to managed care is the ability that the managed care organizations, they have money that they can invest. And so it is a great opportunity to use the resources of our plans, our prepaid health plans, or MCOs, to be able to make investment in those communities. So the food deserts, awesome, you know where the food deserts are, and you have money to invest in those community resources. So we will expect that, and we're also going to do things within Medicaid to make it easy for them to do it. And there's a concept that the medical loss ratio is a concept where there's an expectation that the plans will spend a certain percent of their money on medical care and quality improvement. Typically in other states, if you invest in food or housing or interpersonal violence, that doesn't count as medical care or quality improvement. So they get penalized if they spend that money because they can't put it in their numerator. So we are going to say that it counts. So if you are investing in community resources, we count that as medical care and quality improvement. So you get to put that in your numerator. So you'll be incentivized, at least not penalized. And we also will have a lever that if our plans are not spending the percentage that they're supposed to be spending on patients, and there's a delta, then we can mandate that how you make up that delta is you must invest in community resources. So there's ways that we can really invest in our state where there are a lot of resources, but we also know there's areas where there are no resources. So we can really help our plans focus and invest in our communities, which we're really, really excited about. And then down the road, also within Medicaid, we want to think about what's the true proper risk adjustment. If you just risk adjust the population on their medical diagnosis, you miss this whole swath of risk. And so thinking about, this consistent data collection through the screening, and then through the resource platform where we can really identify what are the referrals and what are the needs. I think it's a way for us to think about how to really start risk adjusting on social risk, which nobody knows how to do nationally, but I think we'll be setting ourselves up to really think about that and I think that's really important, because if we don't do good risk stratification on social risk, you really run the risk of increasing health disparities and the most vulnerable people being disenfranchised and out of our system, and our safety net providers really struggling. So we want to try and not do that. And then the last 3 slides, and then I'll stop, and then we'll have about 15 minutes to talk. You saw some of the stuff that we are wrapping into our bread and butter statewide Medicaid plan for everybody. And then many of you have probably heard that we also, in 2 to 3 regions of the state, and we have not chosen the regions at all, is that we want to try to do some pilots where we can do even more investment and community connections in addressing social determinants. So we are asking the Centers for Medicaid and Medicare, CMS, for the authority to spend their federal Medicaid money. So, most of our Medicaid money is federal, so we have to ask the our federal government for permission to use Medicaid money. So we're asking them for expenditure authority to use Medicaid and Medicaid match dollars for services that address food and housing and interpersonal violence and transportation. So we will have Medicaid money, and we'll be looking to complement that Medicaid money with philanthropy money and private money. So a pot of money where then we can, in these regions, we can say, all right, we know in the literature, we have all this evidence. How do you go from evidence of a single intervention of a single population to how do we roll this out on a population level? And think about addressing housing and food and transportation in a population level, meaning early childhood. How do we think about adverse childhood experience in early childhood, emerging risk, our asthmatic kids who are really poor housing quality, our pregnant women and poor outcomes or experiencing interpersonal violence, and then our adults with a very medically complex high cost. How do we think about really addressing all these elements on a heterogeneous population level? And what we learn in the region levels, then after the pilots, we can think about rolling that out on a statewide level and then incorporating that into our statewide Medicaid plan. So to do that, we have to get really mindful about the pilot and evaluation design. So at the end of this, we have really good data to say, this is how you do it on a statewide level, and then this is what we need to roll into our Medicaid plan. So this is going to be a huge, complicated list. We're really, really excited about it, and there'll be more to come as we flesh this out. We have to, make sure we still have hoops to jump through with CMS. We will be sending folks out, information out as we get through some of those hoops so our community are able to respond. And then more will be coming out probably in the fall or so on more detail on our pilots. And then the last 2 slides, and very quick, is workforce. We really think that there's other elements of our workforce that we aren't tapping into that we need to, and we think community health workers are an incredibly important workforce for this type of work, and we don't have a well-coordinated infrastructure of community health workers in our state. Other states are way, way ahead of us on that. So we've been doing some work on that. This document just came out a couple weeks ago, probably maybe 2 weeks ago, and really what's the state of the state right now, and what's the vision about really building an infrastructure of community health workers and that can be deployed in all sorts of ways. We think that that's a really important workforce that we haven't invested in. And then finally, and this is a little bit of internal work, but I think there's lots of work that can be done at the community level as well, is there's lots of ways that we're trying to bring new resources and more focus in on a population, but there's some low-hanging fruit and things we can do with existing resources right now that we're not doing, and aligning and thinking about how do we do a lot better in getting people enrolled in services that they're already eligible for. And so, for example, we pulled some data and we found that about a third of women whose prenatal care was covered by Medicaid were not enrolled in WIC. And that's a program that's already there. They should be eligible. We know how important food nutrition is. Like, that's low-hanging fruit. So how do we think about making sure we're maximizing eligibility? And then another even more sobering data point. We looked at our older, so our 65 and over people who are dually enrolled in Medicaid and Medicare. And so most of those should be eligible for SNAP or for food stamps. Only a third of our seniors, our duals, are enrolled in SNAP. And the data, if you remember right in the beginning, food insecure adults have higher healthcare costs. You link them to SNAP, you can decrease their healthcare costs. We have 2/3 of our seniors aren't enrolled in SNAP. So there's some really low-hanging fruit. We need to think about how do we do better at a state and how do we do better at our local levels to just take advantage of what people are already eligible for. So we're doing a lot of that work as well. So that gets me, that was 42 minutes with the preamble. So that I will stop there and open it up, and we have 15 minutes, I guess, for Q&A, and happy to clarify or answer any questions that you have.
Great, thank you so much, Dr. Tilson. It looks like there's 3 questions right now in the Q&A. So if folks have additional questions, they can stick them in there. I'm happy to read them off to you if that would be the most helpful thing.
Yeah, unless I don't see them on my screen, so that's probably good. But I'm a visual learner, not an auditory learner, so I will hopefully I can hear well enough to respond.
Fair enough. Fair enough. So the first question is: are there plans for data collected on the resource maps / dashboard to inform the social determinants of health map from the department?
Say that again?
Are there plans for the data collected on the resource maps / dashboard to inform the social determinants of health map from the department?
Okay, I think what the question is, so right now, on the map that we have out of the department just looks at those indicators. I think the question is there thought about how can we map resources on top of that? So you say, like, you have, this is a desert, but these are the resources. Can we superimpose the resources onto that map of social indicators? I think that's the answer I'm gonna, I think that's the question that was asked. Okay, great. So we've had a lot of conversation about that. And so, yes, we would like to do that. And part of it is thinking about, we have so many different data sets and what are the resources and what do we want to map to. And so we want to do that. We want to think about the universe of what data of resources that exist that we could map to and we want to map to. And the first place that we're going to start with is, as we're building this resource platform, the first piece of the resource platform is knowing all the resources and geocoding all those resources and having all those resources in a geocoded way at the resource platform. So when you're searching for resources, you'll know where it is. So we're going to have folks from our State Center for Health Statistics, when we've chosen the vendor, working with the vendor and really think about how you're geocoding all those resources, making sure that geocoding is aligning. What are we doing in the resource platform? And then from there, think about, okay, so the work we're doing in the platform, let's pull that and what do we want to superimpose on the map of social indicators. So yes, we're thinking about it. We're trying to figure out how to do it in a staged way and how to do it in conjunction with the resource platform, so it's all kind of aligned.
Great. The next question is, has the department considered expanding to other social determinants of health that are child specific, such as early childhood development or access to childcare?
Yes, a lot. As I mentioned, that the core ones are the kind of core ones we want to resonate around, and we wanted the core ones to be applicable to all populations. So that's equally applicable to our elderly and our adults and our kids. So part of the reason we chose the core was that applicable to everybody. But we also know there's a lot of other very really, really important resources, especially in different populations. So I'll answer that in 2 ways. So one, when we talked about this core set of screening questions, if any of you looked at that white paper, we also had a set of optional questions. And so if you're in a very child-oriented agency and you wanted to add optional questions that were very child-specific, have at it, absolutely, and we gave you ones to choose from. So and then if you're like in a OBGYN, you really want to think about more in a partner violence. So different settings will want to think about screening questions that are a little bit more applicable to their population. Then when we get to the resource platform, absolutely. And in fact, what we know that there's going to be a lot more resources that are out there. But in terms of holding the vendor accountable, we wanted to make sure we had to identify some core ones that we could hold the vendor accountable for, making sure that you were delivering on those core ones. But we've already had lots of conversations, and we know there's a lot of other resources that can easily be brought into the platform, and probably will be right at the start. And we've also talked about, and I don't know if this was a question that came from Guilford County. We've had lots of conversations with Guilford County because they're trying to build something that's very, very similar, and that we'll kind of have like a core piece of the platform, but we can easily see there'll be additions that can be added to it that are more focused. And we actually had a really great meeting with a bunch of health funders the other day, and we could easily see that there could be additional funding that expand to other resources as well. So that was a long way of saying, yes, absolutely. We anticipate that it'll probably be there right from the beginning, but if not, we'll be building it. And we know that's really important. And yes, and we really see this platform. The platform will continue to expand and have different functionalities. We would love it also to be that you can do it and you can enroll in WIC and SNAP from the platform. Like, there's so many things that we'll be able to build on it. So that was a long way to say yes.
Great. And then another question is about McV. So do you know if there will be additional funds to support prenatal infant home visiting programs for counties that don't have access to McV funds?
That is our goal and our hope, and there's different ways that we can think about increasing, and we're talking about home visiting programs, maternal child health visiting, home visiting programs. So yes, that is our goal, and we're also a different segment of work, and perhaps another webinar, is that we're also, this year, we're working on an early childhood action plan as well, and really thinking about some of our priorities, and then thinking about how do we then invest in those priorities that align with our early childhood action plan. And home visiting programs, those evidence-based home visiting programs, are absolutely initiatives that we feel need to be funded and additional resources. So some of it we can use our Medicaid money for in terms of those pilots, but there's other buckets of money as well that we can use it for. So that is fully our intention, is to really invest. And I think about it more when we talk about the early family resiliency model. So not so much it's a home visiting model, but more global of our early family resiliency. So yes, that is our plan, is to really think about and how do we, in a coordinated fashion, invest in our early childhood home visiting and family resiliency program. That's a big priority. And it's been great, been in meetings with secretaries saying we need to get money out, we need to get resources out, we keep saying it, now we need to get money out. So that's our goal and our plan, and we're working on trying to do that in a kind of strategic, coordinated way.
Great. Then there are a couple of questions here about the medically fragile population and how they fit into managed care. I don't know what exactly the relationship between social determinants of health, but I'll read off one of the questions and let you either answer or you can refer to someone else. So how are you thinking about the high need, high cost children due to things like genetic disorders that aren't preventable through the screens that you're applying to other CAIDM recipients? As a community, we're concerned that the only way to reduce costs is to reduce services. What protections will be in place to ensure that PHPs don't profit by cutting needed services?
Yeah, so let me level set and first say that there are so many things we'll be doing in our Medicaid program. Social determinants is one piece of it, but that's certainly not the only piece we're doing it, and very, very, very mindful of medical complexity, all sorts of other populations. So just because you don't see your population obvious in this, what we've been talking about today, does not by any means mean that it's off our radar and we're not, won't be attuned to it. And in fact, we just had a conversation today thinking about the medically complex children and the interface between the care management that's going to come from the prepaid health plans, and then CC4C, and a lot of our medically complex kids are also socially complex. And so how do we really make sure the intensity of the care management for those medically complex kids is in place. And then also really holding our outcomes as well. And I think if services start getting cut as a way to save costs, services start getting cut. And you'll start seeing that in terms of health outcomes. You'll start seeing that in terms of complaints. You'll start seeing that in terms of patient satisfaction and provider satisfaction. So there's many, 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 many tools that we are going to be put into place through our contract, through our oversight to prevent just that. So there's lots of ways that we're going to be mindful of protecting our most vulnerable patients through a lot of different levers that we have and contractual oversight. So we're very mindful of that, and we'll put in as many legal and contractual levers to guard against that, as well as to guard against cutting it, but even more so, make sure we have the infrastructure to really be able to respond to the needs of those kids and those families.
Excellent. The next question is about existing resources in place. The person writes that there are existing resources in place, such as Meals on Wheels, Table, Porch, Eastern NC Food Pantry. Why not draw off of those programs? And I think, anyway, I will let you answer the question. How about that?
So I would say absolutely. Yeah, that's our plan.
Yeah,
yeah.
That's my understanding too. Is to
absolutely.
draw
we are not recreating no, that is absolutely 100% our plan. There's 211 in place. We want to draw on that. There's so many existing resources, and we are absolutely going to be drawing and engaging them and making that part of it. So yes, is the answer.
The next question is, are there efforts to address some of the fundamental reasons why people are food insecure or have no or poor housing, such as living wages, barriers to folks who are previously incarcerated, et cetera, is the question.
Yeah. So we've thought long and hard about this, right? And so, what's also historical institutional racism. There's so many things that get us to this place of health inequity. So we recognize that what we're addressing is almost a symptom of a much, much broader thing, right? And so we've talked about some of the best things that we can do to improve health is how do we promote economic viability of our rural areas? How do we get broadband out to our rural areas so that we can attract businesses? If we attract businesses and people have a job and they be able to, so this is a huge issue, and we're trying to think about it as cross-cutting, not just across the department, but across the departments. And how do we really think about improving the health of our communities as a whole? So yes, that's on our radar. We also are thinking of, and we had as I mentioned, we had a great conversation with a bunch of our healthcare philanthropy just on Wednesday, saying what could be the big vision for health and health disparity and equity. What's that big vision? And then how far is that can we do with DHHS and the money we can bring in, or is it how can we make sure that we're leveraging the money we have, which is a little bit more health focused, into that broader vision, but create that broader vision and then pull in philanthropy or other places to match that piece. So somewhat of a pragmatic approach to a bigger vision, because we know that's a bigger vision. But concretely, as much as we can get to that upstream even more concretely. So it might be hard, and we've thought a lot about people's barrier to jobs and housing because of their legal status. And so we will have, as part of our expectation of our PHPs, that they have a legal specialist, a housing specialist, and a legal specialist as part of their care team. Because if you're blocked out of housing because you have a felony record, you're out. So how is it that we can have the legal and housing specialists help you navigate that? So there's some ways that I think we can do it in a more proximal fashion with our health dollars and what we need to be accountable for, but being brought into this bigger vision that's more global health and helping to support that as well. So you have to kind of start somewhere, but we know where we're starting with it almost still feels downstream. Like, how is it that you're food insecure in the first place? We feel like we're upstream, but not nearly enough as upstream as we want to get to, but we're starting to move in that direction and partner with people who can be even more upstream than us.
Great. Then one question, I think it's a follow-up from one of the previous ones, is how can us from Western rural counties get involved in the ECAP?
In the ECAP, help me.
I didn't spell it out because I don't know what it means. So
that's in the western part of the state.
Yeah, Lance is the person who wrote this question. Early childhood action plan. There it is.
Oh, early childhood action plan. Yay! Okay, thank you. I'm sorry. We started with a more internal group, and now we're reaching out to more external stakeholders and pulling them into the work group as well. And so we're partnering with some of our pathways and a lot of our other groups that are working on early childhood. So if Lance was the person, if he wants to, my email isn't on here, but if he wants to get to you and you can get to me, then I can connect you with, so Susan Perry Manning, who's our deputy director over this, and I'm helping to lead that as well. But if Lance wants to give us his contact information, we can make sure that they get plugged in.
Perfect.
Yeah, and forgive me, I shouldn't have. So acronyms are not, it's a danger of acronyms that I should have even known that's our own acronym, and I didn't recognize it, so.
We live in a world, an alphabet soup world.
I know, I try not to speak in that.
So our last question is one that I'm sure you cannot answer, but it still might be interesting to throw out there and for you to speak to. So it is, what are the possibilities for Medicaid expansion? And the question reads, while 500,000 North Carolinians still do not have access to that program, that seems mighty important. So that obviously gets into some pretty serious politics, but I think, it'd be great to hear your insights on that if you have any.
Yeah, actually, so I have thoughts on that. So there's a couple things, and I know I'm not going to miss it. So first off, I think language really, really, really matters, and words really, really matter. And I say that for a second because I very briefly I said social determinants of health, and we hate that term, and we're actually moving to different language, and hopefully you'll start seeing that. We want there to be healthy opportunities, and we want all North Carolinians to have the opportunity for health. And we know to have the opportunity to health, then we need to address those drivers of health, like health, housing and food. And anyways, language matters, and how we talk about social determinants, so you'll see some turns of phrase. It also really, really, really matters when we talk about insurance coverage. So the first thing is, I would say, we want to close the coverage gap. Medicaid expansion is not a great term to use. We want to close the coverage gap. We think it is really important, incredibly important, in addressing the opioid epidemic. 50% of our people who are struggling with addiction are not insured. We cannot get them into treatment if we can't close the coverage gap for those people. We know that parents who are insured, then their kids have better health status. And our parents who are uninsured and struggling with addiction, they can't get into treatment, and then we have all the ACEs and the kids. So we think closing the coverage gap is incredibly important if we really want to move the trajectory of health. There is, as people know, legislation that is proposed, Carolina Cares, and we are huge advocates and proponents of it, and we talk a lot about the importance of closing the coverage gap, and the General Assembly is very aware that we are very much in support of closing the coverage gap as a really important way to improve the health and decrease costs to the state. So we will see.
We will see. We will hope. All right. Well, that is our time, and those are all of our questions. So we got to everything. I just want to thank you, Dr. Tilson, for taking the time out of your schedule today to do this. It's been extremely helpful. And for all of the attendees, we will send out a recording of this so that you're able to reference back to it later on. And yeah, I don't know. Do you have any final words for us, Dr. Tilson?
No, I just think it really is exciting to be out with people and talking about these concepts. I think it's been so intuitive for so long, and it's really exciting to see how many people are excited and engaged in it. And I think that this is clearly something that we cannot do from the department alone. This is so dependent upon everybody working together. And so it's been really, really exciting to see the kind of excitement and support and encouraging from everybody. So I'm really, really appreciative. And I think even, your interest even to participate in this is evidence in that. So I really, really appreciate your interest and support and us partnering as we go forward.
Great. And Dr. Tilson, it would be okay if I shared the slides as a PDF with attendees?
Yeah, that is fine. Yep.
Great. So those will be shared. And yeah, I hope everyone has a wonderful weekend, and we'll, I'm sure, be in touch very soon. Thank you.
All right. Thank you.